I'm Adam Bonoslawski, Senior Editor at Genome Web and 360DX, and I'll be your moderator for today. The title of today's virtual roundtable is Current Trends in Nucleic Acid Testing for HIV and HCV, and is sponsored by Hologic. Please see resources available for download on the left side of your screen. Our panelists today are Ping Ren, Professor of Pathology and Associate Director, Division of Clinical Microbiology at the University of Texas Medical Branch; Nathan Ledeboer, Professor, Medical Director, Clinical Microbiology, Medical Director of Molecular Diagnostics at the Medical College of Wisconsin; Sarah Buss, HIV, Hepatitis, STD, and TB Program Manager at the Association of Public Health Laboratories; and Stan Schofield, President at NorDx. You may type in a question at any time during the webinar. You can do this through the Q&A panel, which appears on the right side of the webinar presentation. And if you look to the bottom tray of your window, there is a series of widgets to enhance your webinar experience. And with that, let's begin our panel discussion. So to start off, I want to ask, what are the changes that have occurred in recent years in terms of where in the laboratory molecular testing for HIV and HCV is being done, and what personnel are doing it? Dr. Ledeboer, would you like to start us off with that one?
Sure. Thanks, Adam, for having me today, and thanks for shooting the question my way. So I think we've seen a number of changes in terms of who's testing, the number of laboratories that are doing testing, and the frequency that testing is being done. And much of this has been promoted by two primary factors. Number one, through the pandemic, so many of us were able to purchase additional instrumentation, and we're able to diversify the instrumentation that we may have in our laboratories. So it's given a lot more opportunity for labs to expand their test menu because they have the instrumentation. The second thing that's been a major driver is the number of instruments that have an FDA cleared solution for HIV or HCV. We've gone from really having 2 to 3 manufacturers, where in many cases we now have up to 5 manufacturers that have FDA cleared tests for HIV and HCV detection. And third, where testing is being performed has changed significantly for the clinical laboratory. Number one, most of this testing is now being performed in the clinical microbiology laboratory because these fully automated instruments may be located in the microbiology laboratory, and it's additional menu that they can add. Historically, much of this testing was maybe done in the molecular pathology lab, but because the systems are so automated, and because microbiology has one of these automated solutions, we're seeing movement towards the microbiology laboratory, with techs that work in the microbiology laboratory performing the testing on those instruments. And the final comment that I want to mention is the frequency with which we do testing has improved. So one of the great benefits that a lot of the testing manufacturers have delivered is they're now using common cycling patterns. So instead of having to have a dedicated HIV run, a dedicated HBV run, a dedicated HCV run, we may be able to develop combinations of those tests that can be run together, which means that we don't have to have dedicated runs, spend money on controls, spend time on the instrument actually cycling or running those specimens. We can instead combine them into a single batch, allowing us to perform testing and report testing a bit more frequently.
Okay, thank you. And Dr. Ren, what are you seeing in your lab in terms of changes in where testing is being done, the type of personnel who are able to do it?
Yeah, and first of all, and thank you and invite me to be in this panel. Okay, in terms of this question, yeah, and at UTMB, HIV HCV viral load assay were performed in the molecular diagnostic lab using Abbott real-time HIV HCV kits and M2000 system. Then in early January 2021, we moved those assays to Hologic Panther Aptima platform. One of the driven is the director of the pathology have the vision to move the infectious testing towards the clinical microbiology laboratory. The molecular diagnostic lab at UTMB mainly focus on the medical genetics and the genomic assays. And also because of we have the Hologic Panther system already in the laboratory, since the Hologic had FDA approved for these tests, this transition becomes much smoother. The assay because of the history, for the complexity and the less automation in the molecular lab, they do the genetics testing. Quite a lot of techs actually had a PhD degree even to run those tests. Of course, for HIV, HCV tests, not exclusively ran by PhD level people, but they do a lot those tests. Then since moved to microlab, the tech have already had a training using the Hologic Panther to do other tests like CT, GC, NG test, HPV also. Those, although it's qualitative assay, but the handling is quite similar with quantitative assay. So those techs in microlab can pick up those tests really quick.
Okay, great, thank you. And Dr. Schofield, what are you seeing in this regard?
Well, we've seen, and first of all, thanks, Adam, and thank you, Hologic, for the sponsorship today. It's important that we have these kind of forums, and your sponsorship goes a long way to help advance the field and the testing technology. I'm the president of a regional lab, and as a regional lab, we're not academic, we're a production lab. So we're the core lab for 12 hospitals, and we compete in the community and the marketplace against large commercial laboratories. So what we've seen, because of the pandemic and the instrumentation switches, mostly for us, has been to move away with new technology to sample to answer kind of technology like Hologic, and away from batch testing. Batch testing served us well. The instruments were getting a little long on the tooth, and going through the COVID and the pandemic and the demand on all the instrumentation, coming out, sample to answer is a lot easier, partially because staffing remains a problem for us. And we've had a loss of intellectual capital where some of our most talented and qualified people have retired and or left and gone to work for industry. And as such, we didn't have the bench depth that we used to have for batch testing or even lab developed tests. So our big change has been moving more to sample to answer technologies.
Okay, great, thank you. And Dr. Buss, what are you seeing in terms of just where there are changes in molecular testing and the type of personnel maybe who are doing it?
Sure, and I'm happy to be here representing kind of the public health voice. And I think in terms of the public health laboratories, a lot of what's been said still applies. We have seen kind of a shift towards more laboratories performing testing in-house, and I think Nathan spoke to some of that with labs getting instrumentation with COVID and being able to put different types of assays on a single platform. That's just led to laboratories that didn't traditionally perform HIV or HCV molecular testing, bringing it in-house. And I think, a lot of what's been said just applies across the board to public health labs. The testing has become somewhat easier with the sample to answer platforms. and doesn't require as much dedicated space as it used to. Although the instrumentation can be large, you don't need the dedicated, extraction room and clean room and things like that. There's just an instrument you can put samples on. So I think that's just led to kind of more availability in general in our member laboratories.
Okay, great, thank you. And so next, we're just interested. I know you've touched on this to an extent, but what are kind of the larger lab industry trends that have been driving this change? Dr. Schofield, would you like to start us off with this one?
Sure. Really, right now, I would say there's three major trends going in healthcare affecting the laboratories. One is staffing, which is really, really hard. We've lost a lot of talent. We've lost a lot of seniority, and people have just stepped away from the field. COVID drove a lot of people out. Industries offered them more money. And so we still have a pretty good gap in staffing numbers that are required to run laboratories. Entry-level people, phlebotomists, lab assistants are particularly difficult. We used to compete against restaurants and pizza parlors, and now they're offering benefits and 401ks also. So it's all about money. So staffing is the number one issue today for the lab industry. Most labs are running 15 to 16% vacancies across the board nationally, with the big trade federation, the Compass Group, that's on average between 15 and 16% across all fields in the lab. The second is automation. Everybody's trying to do more with fewer people because we don't have the people. The cost of automation has gone up. Instrumentation, we're a perfect example. We used to do large batch testing, a lot of lab developed tests, and we're moving sample to answer and more automated platforms, ease of use and flexibility for automation. Not even going to get into the informatics piece and the digital piece, but that's a huge driver at huge expenses. And then the final area that's really hitting the labs and continues is reimbursement. It's getting harder to get paid. In the last 7 years, we're down about 49% per dollar billed from what we got paid for the same test due to PAMA cuts and insurance cuts adjusting Medicare rates. So reimbursement is still a challenge. And if you get into more advanced complex testing, the denial rates are going up, needing pre-authorization. So anything around oncology and viral loads is subject to some serious fighting with the insurance companies from time to time around payment. So those are the big three trends, I would say, for your audience today that impact everybody that's on this call.
Okay, great. Dr. Ledeboer, what are you seeing sort of in terms of industry-wide trends and how these things are affecting the HIV, HCV testing?
So Stan definitely hits some of the really important components to trends that are impacting laboratories in general, but I think I'll hit on a couple of additional points. The first point is lab stewardship. For the first time, we're hearing increased emphasis on laboratory stewardship. Right test, right patient at the right time. And in particular, as we think about HIV and HCV testing, that means our providers and our patients expect that if they come in for a blood draw and they need a nucleic acid confirmatory test, as an example, that can be done off of the same sample. So we're seeing kind of make it easier for the patient, and again, make it easy for the provider to do the right thing and to make sure that we're not doing a lot of over-testing. The second thing, specifically as it relates to patients, is patients want testing to be more convenient. Getting in the car, driving to the hospital, driving to a phlebotomy site isn't something patients want to do necessarily. Wait in line, not things patients want to do. So where we can deliver testing nearer to where the patient lives, that's better. If we can come into the patient's home, that's even better yet. So I think we're going to see a significant trend towards really addressing what are our patients' individual needs and bringing testing closer to the individual patients themselves. And that'll be non-traditional locations like pharmacy-based testing and things like that. And then finally, I'll also point out as it specifically relates to HIV and HCV testing, we're also seeing increased need for testing, not only for monitoring, but for the purposes of diagnosis, which I know we'll spend some more time talking about a little bit later on.
Okay, great. Yeah, thank you. And Dr. Ren, what are you seeing? What trends in the industry are impacting your lab, and how are you seeing that reflected in your HIV and HCV testing?
Yeah, I want to emphasize like high throughput, really need a fast turnaround time, and also maybe cost saving. That's part of the factors. I can just give you our institution example. We have the sample volume size about 600 to 700 per month for HIV and 14 to 1500 for HCV. Before pandemic and right now pretty much stayed the same. However, before transition to our laboratory, the turnaround time was about 4 to 5 days for those assays, because it's batched test to save the cost, to have to wait basically full 96 well plates to be, the plates to be full to load the samples. And after changing to our laboratory, our turnaround time becomes 24 to 36 hours. So basically saved 3 days. So that's very important actually, and for physician to know patients' results, patients themselves to know their results, and don't have to be wait forever kind of thing. So that's the driven. That's the driven. Also for the HIV test, when transitioning to our lab, since this assay also is FDA approved as a qualitative assay, so we don't have to send out the HIV qualitative assay to the reference lab anymore. Definitely save time and the cost.
Okay, excellent, thank you. And Dr. Buss, I'm wondering, are the trends that are affecting the broader lab industry also impacting the public health space in the same way, or what are you seeing that's the same and different, and how is this impacting your HIV?
I think a lot of what's said applies across the board, right? Certainly what was said in terms of the instrumentation, and workforce shortages and things like that. I think within the public health community, we have a push for health equity. And that applies to what Nathan was saying, specifically with equitable access to testing services, which does drive the testing closer to the patient. So I think within the public health space, that is a driver of change these days, along with, like I said, a lot of the other things that were mentioned specific to the instruments themselves. And of course, cost is always a factor. I think our laboratories have a little bit different approach than a clinical or a commercial lab, in that most of them are not billing for testing services. So, as costs come down and more labs are able to do the testing, but funding's another issue we can discuss later on.
Okay, great. Also wanted to discuss, aside from these industry-wide trends, what are sort of the trends in HIV and HCV testing more specifically, that are driving some of these changes we're seeing? Things like maybe increasing PrEP treatment or changes in testing algorithms. Stay with you for starting off this one, Dr. Buss.
Sure. I think there's so much to say with respect to this question. When it comes to HCV and testing algorithms, within the field, I think that people want to see a single step testing algorithm with viral detection first, but that needs to be done in a cost effective and affordable way. We don't have that yet. And I think the drive for that is because it can be a challenge for labs to complete the testing algorithm, a screening test and nucleic acid test with a single sample. And then that places the patient at risk to loss to follow-up, and nobody wants to see that. But right now we have to kind of work with the algorithm that we have, data for, the algorithm that we have FDA cleared tests for. So I see some focus on completing that algorithm with a sample collected during a single patient visit. At APHL, we do have data that shows when labs perform HCV RNA testing in-house, they're more likely to be able to complete that testing algorithm versus labs that have to send a sample out to get that RNA testing. So that may also be a driver of the labs bringing testing in-house. Within the HCV space, I think the new therapies we have available, the pan-genotypic direct-acting antiretrovirals, they are kind of leading a shift away maybe from genotyping. And within the public health space, I think sequencing is probably still important, but maybe a shift away from the genotyping. When it comes to HIV, we've seen these kind of dual claim assays, so quantitative assays that have dual claims for diagnosis as well as clinical management. And I think these are driving a change in the field. Our public health member laboratories typically have performed more qualitative HIV testing than quantitative, but I think that's going to be changing along with these dual claim assays coming online. And I think that has some potential implications in terms of laboratory stewardship as well, where a quantitative viral load assay was the first thing that a patient would get after diagnosis, and now you can kind of get that simultaneously. And let's see, so I haven't touched on PrEP yet, and I think that's another big force in the HIV field. When it comes to PrEP, there's a lot of impacts on testing, driving demand for, like we talked about, near to patient testing, because when patients are taking PrEP, they have to be tested on a regular basis. And so, challenges in getting to a testing location are much more problematic when you have to be tested regularly. So that is driving the demands for near to patient testing. But PrEP's also creating some nuances with testing. We tend to see some discordant results these days, and this is requiring laboratories to rethink the data that they collect in their LIMS system, because we know that a lot of our laboratories don't know when a patient is on PrEP, and I think that's problematic. And on top of that, I think we have some of our labs who would really like to see an FDA cleared test for total nucleic acid when it comes to HIV to help resolve some of these discrepancies that PrEP can be driving. So I know that was a lot of varied topics, but good question.
No, that's great. Dr. Ledeboer, what do you think on this one?
So actually, I want to first react to one of the comments that Dr. Buss made it just in her last comment, and that is access to testing. And we're seeing a major shift today in access to testing, especially to HIV, but also to HCV. We're seeing increasingly medical centers are offering HIV testing in the emergency room population. So we know patients that present to the emergency room, a large proportion of that population is otherwise not engaged in care. And so this is a significant opportunity for us to get these patients into testing, get them into screening while they are presenting to our emergency room. So what we're seeing is we're seeing every patient that's going to have a blood draw being approached in a lot of centers around. It is our standard practice to do HIV testing. Because you're going to be getting a blood draw, we'd like to offer you HIV testing, and we operate on an opt-out basis for that HIV testing, allowing the patient, if they choose to not want to be tested, to not be testing, but really encouraging that testing. We implemented this about a year and a half ago in our own medical center, and we found on average 2 to 3 patients per month are being identified as new diagnosis HIV patients that otherwise would have been missed. So this is a significant opportunity to get people into care that otherwise may not have a primary care provider or something like that. So I think this is a really important shift that we've seen in the industry, and that's really getting and driving access to care. The second thing, as Dr. Boss mentioned, is PrEP. PrEP is creating a lot of both opportunity and a lot of challenges. One of the challenges that many laboratories are seeing is when, and in all of the PrEP package inserts, it is required that patients not only get an HIV antibody test, that they also get a nucleic acid test. A lot of the insurance providers or a lot of the third-party payers haven't yet adopted to that change. And so what we're seeing is, at least from a clinical lab perspective, we're seeing denials around those because the insurers are saying this is testing that should be reserved only for monitoring. So this is another place or another challenge that we're encountering as we're seeing changes in the algorithm to including molecular diagnostics in the diagnosis of HIV. The third thing that we're really seeing and that's really beginning to happen is reporting. I live in a state that has a phenomenal public health infrastructure, and HIV is now universally reportable. So we have to report HIV antibody results, confirmatory results, as well as viral load results. And again, this is really focused on getting patients into care. That's created both opportunities and challenges for patient follow-up. So the patient that gets an HIV test, how do we make sure that once they've gotten that HIV test and it comes back positive, that they're getting into care and that they're staying in care? And we're starting to see a lot of partnerships between the public health enterprise and the clinical labs and the clinical enterprises around getting those patients into care and ensuring that they're staying in care over the long term. This is all on top of some of the diagnostic algorithm changes that we're starting to see. And I fully expect, as Dr. Buss mentioned, that we're going to see primary molecular diagnostics in the very near future. Finally, I also do want to mention, and I think it's worth discussing, we have gotten so good with a lot of these assays. So we're down in the example of HIV to, in many cases, under 20 copies per mil or international units per mil, depending upon what mechanism you're using or what unit of measure you're using. We're so good to the point that we're actually creating challenges for our provider colleagues. The goal has always been with HIV, get patients to undetectable. But when a lot of that guidance was originally developed, the analytical sensitivity of our quantitative HIV assays was 200 to 500 copies per mil. Now, when we're a full log lower than that, oftentimes, and depending upon the regimen that the patient is on, we may not be able to get down below 20 copies per mil or get to undetectable. That creates a lot of angst in our patients because our patients have been trained, we need to get you to undetectable. And when they're 20 copies, 30 copies, 50 copies, they see a number and that creates angst because they're not undetectable. So really, how do we communicate these improvements to our patients? And how do we communicate this is not a treatment failure is a really important conversation that we need to empower our clinical colleagues to have.
Okay, great. Thank you. And Dr. Ren, what are you seeing, I guess, specifically in the HIV, HCV testing that's impacting the way you go about this in your lab?
Again, I want to talk about our institution. It's our population for these tests may be different from other places, because at UTMB we have the incarcerated population, have TDCJ hospital. 80% of the inmates care laboratory tests that come to UTMB. So that's being that said, so the algorithm change for these tests more sensitive, more specific, and it's really important. And also early detection will lead and prompt physician taking care of the patients. And so it will improve patient management. I would just say that part.
Great, thank you. And Dr. Schofield, what do you see in terms of the HIV, HCV trends and how they're impacting the way your lab goes about business?
Thanks, Adam. Well, a few years ago when HCV became a standard of medical care for most adults to be tested, that drove a large volume increase. And that volume has been sustained. And the protocols for value-based testing and contracting remain in place. So the volume has remained consistent. What we are seeing now is that HIV, because of some of the new protocols and changes, we're getting denials on payment for those few patients that do have insurance. Predominantly, we do a lot of community and public health testing of clinics and services as part of our mission. And there's not a lot going on with billing, but the insurance companies are denying payment around some of the new HIV testing protocols. And it's yet to be resolved within the insurance industry as the standard of care. So that's kind of our big thing. HCV volumes remain strong, and therapies, a lot of people are in therapies. So it's a standard of care that we sustain and maintain on a daily basis.
Okay, great, thank you. And I know we touched on this briefly, but I wanted to go a little more in depth on this question. You've had a lot of molecular capacity expanded during COVID-19 with labs that maybe didn't have it, adding it. I'm wondering, how has that influenced what kind of labs and where HIV and HCV testing is being done? I was wondering, Dr. Buss, could you start us off maybe with the public health perspective on that question?
Sure. I think we touched on kind of the simple side of it, where more labs got the instruments they needed to do COVID testing, and then they can use those same instruments for HIV or HCV testing now. In terms of some of the, the pop-up sites that were established for COVID testing, I think it's a little bit mixed. A lot of our laboratories have kind of began weaning those down, and they don't necessarily have access to those sites anymore. However, there's a really cool model that Dimitri Daskalakis, who's now with CDC but used to be at New York City, talks about, and that's the New York City Quickie Labs. And he talks about the flip, right? So in these Quickie Labs, these were STI clinics in New York City that did kind of near to patient testing. And when COVID hit, they were able to be flipped into COVID testing laboratories. And now they're being flipped back into the STI labs that they started. But what COVID did for those was rapidly expanded the number of laboratories that they had in these kind of nearer to patient locations. So that's kind of a nice example of how very practically COVID actually helped in terms of where HIV and STI, not necessarily HCV testing, was occurring in our laboratories. But I think for the most part, it's what we touched on, in terms of instrumentation.
And Dr. Schofield, in sort of your setting, what have you seen in terms of expanded molecular capacity?
Yeah, ours is a different construct. Having 12 hospitals, we don't have the population density like in New York or pop-up labs. We just don't have that kind of patient population, risk population either. So most all molecular is centralized into a core laboratory as part of the health system network. And the Compass Group, the big trade federation I run, they also have large, 30, 40, 50 hospitals and core laboratories. And most of this kind of testing is not being decentralized. If you have extra instrumentation, what's happening is the instrumentation is being consolidated and brand numbers are being reduced. And this type of testing is still being pretty much directed into a central location. Now, there are big cities and there are large hospitals that have clinics and supporting roles, and there may be some kind of HIV, hepatitis C testing that's warranted in those kind of communities on a real-time basis. But overall, this type of testing is centralized for staffing and automation and cost effectiveness, just about most of the big health systems that I know of.
Great. And Dr. Ren, what have you seen? Did your system expand its molecular testing capabilities significantly during COVID? And I guess if so, has that influenced anything about the way you are doing your HIV and HCV testing now?
Yeah, actually, during the COVID time, we, in order to increase the capacity to just test the COVID, we did acquired another Panther from 2 becomes 3. Then we also added another fusion part to one of the Panther. This expansion definitely helped us transitioning the HIV, HCV, and also HBV viral load assay from the molecular lab to our lab. That expansion made it possible. Otherwise, it will be difficult juggling all those tests with large amount of inquiry for the COVID test. Right now, we know the COVID test is down. However, this expansion is still really helpful. And not only on those HIV, HCV tests, we can actually have the opportunity to transfer another laboratory development. It was in our lab, but on a different platform. It's LDT, but to the Hologic system. That was the CMV viral load. At the same time, with the Candida auris, this thing going on, we had the opportunity to use the Hologic system Panther fusion part to validate LDT test on the Panther. Although maybe this didn't answer your question directly, impact about HIV, HCV test, but I just want to say this expansion have a potential to compromise a lot of other tests that's we are facing.
Great. And Dr. Ledeboer, what has your facility's experience been?
I mean, I think, much like Dr. Schofield said, we're a large laboratory when we're a system laboratory. So we've always done HIV testing. We've been able to have dedicated HIV testing instrumentation. I think the biggest trend that we've seen happen is, in addition to increased placements of instruments, it's also the increased democratization of testing. So historically, you had one or two vendors that were offering an HIV test. That meant that only the very large labs with large volumes could justify doing it. With more vendors now offering it and having common cycling platforms, this really increases the ability, even for a lab that may have low volumes, to do their own HIV testing. And I think that's really the biggest trend, and that's really increased who can do testing. It's the menu expansion. So the vendors are really thinking about, what is my menu? How do I address different areas of the market? And so that I'm not a dedicated respiratory system. Instead, people can do respiratory testing, they can do HIV testing, they can do HCV testing, they may be able to do transplant virus testing, all on the single platform. It justifies having that platform, and it justifies the expanded menu because I don't have to have a dedicated run of HIVs instead. So I think that's probably been a bigger and more impactful factor, is just the increase in size of menu from a variety of different vendors that's ultimately created a lot more opportunity for labs to test. So I just think of the example of our children's hospital. We would never have looked at an HIV testing platform in our children's hospital because, quite honestly, the volume wasn't there. But if we can do flu COVID testing, if we can do transplant viruses, if we can do HIV, now that might make sense, especially if we can use common cycling parameters.
Okay, great. Thank you. And then we wanted to kind of look to the future. I guess look at both what are the kind of major challenges and pain points that labs doing HIV and HCV molecular testing face right now, and how might they be addressed? Are there any future technologies or workflows that you see emerging that could address some of these problems? Dr. Ren, wanted to let you start us off with that one.
Okay. I still will specifically talking about current platform we are using. Although I have said a lot of good things, one of the major challenges for us right now, because the large sample volume, we have to do some the centrifuge, so many samples at once prior to load onto the instrument, and tech must be able to handle this task efficiently while simultaneously multitasking many other tests. And then also the current platform require making the reagents quite, how to say, maybe called very finicky, if not doing it really articulated. So then, of course, we have to overcome this drawbacks, like we train the tech really well and help them to have the good habits for doing those tests and organize it well, articulated in order to run the assays perfectly, basically. I mean, for future, we can see it's maybe throughput-wise, the sample preparation even less stringent in terms of because of volume, it will becomes more and more. It's part of the challenging. Yeah, that's
okay. Great.
What I can say right now.
Okay, and Dr. Buss, you have any thoughts on this?
Yeah, I mean, I think there's, for me, two that stick out, and that is kind of regulatory restrictions. So we hear a lot about age limitations associated with these tests that create challenges for our laboratories, as well as a lack of variety in specimen types that have been FDA cleared. We have a lot of interest in alternative specimen types, and we haven't really talked about that. So like dried blood spots, or sample types that can maybe be collected by the patient at their home. But there's regulatory challenges with actually bringing those to the laboratories and getting testing done with those alternative specimen types. So I think studies can solve that, and kind of companies going to the FDA with maybe a wider variety of specimen types when they complete their studies. And then I mentioned it before, but in the public health space, we have some data that indicates only 45% of our member laboratories bill for HIV and HCV testing. So, I think funding for the testing is a major challenge, especially if we move towards a single-step algorithm with either of these that put molecular testing first, which tends to be a little bit more expensive. I think that would be a challenge for our laboratories, but not necessarily a bad thing, but just a challenge that would need to be kind of rectified with funding.
Okay, great. Thank you. And Dr. Ledeboer, what do you think about this?
2 specific points, Adam. First of all, I think as we continue to see more and more utilization of either molecular as a primary diagnostic or as a reflex diagnostic, we need to continue to work towards ensuring a lack of sample contamination. So Dr. Neil Anderson from WashU has spent a lot of time talking about this particular issue. And for so many of these specimens, they're coming off of a chemistry analyzer. And we don't use barrier tips on chemistry analyzers, which increases the risk of a low-level RNA contamination, RNA or DNA contamination. So I think whatever we can do to kind of minimize that contamination from a manufacturing or an operations perspective, that's an important consideration and an important advancement that we really could make to improving the ability to reflex off of the same specimen. And the second point that I want to make is the other advancement I think we need to move as we move closer and closer to a molecular and nucleic acid-based assay being the primary diagnostic, moving that testing closer to the patient, true random access testing to allow a result to be reported while the patient is still there. I think that's ultimately the goal we want to move towards.
Okay, great. Thank you very much. So I wanted to thank our panelists and also remind the webinar participants, if you have a question, please type it into the Q&A box in the control panel. And we'd like to ask attendees to take a moment after the webinar has ended to take our exit survey and give us your feedback. And we'll now start the Q&A portion of the webinar. And the first question is, it's getting back to something we touched on earlier about the sensitivity. And, does the improved sensitivity of the HIV nucleic acid tests and the desire to get patients to undetectable levels, does that suggest a need for a qualitative test that might better reflect the guidance patients and clinicians have received? I was wondering, Dr. Ledeboer, since you brought this up earlier, maybe you want to start with this.
So I think this is a really interesting, it's an interesting way to think about this, and it's an interesting consideration. Despite the fact that I think it creates some patient confusion, from a clinical standpoint, there's a lot of value as well in knowing what that viral load may be. It can and being able to follow that. So because it's important as we think about the management of this patient, it's important to think about this over the context or over the term of their care. So if we think about that of a long-term monitoring perspective, is that slight bump or that viral load of 30, 40 ultimately just a blip? Or is that a long-term trend that we need to be paying some attention to and potentially following up? So I think there's value in still having a quantitative viral load and being able to follow that. This really comes down to, though, is how do we communicate this information to our patients and really reestablishing what is the definition of undetectable. And it's also really important to note, this is more applicable to certain therapies and less applicable to others. And we could spend an entire webinar talking about which therapies this may be applied to, and we're more likely to see breakthrough viremia. Yeah.
great. Thank you. And we had a question about reimbursement, and in particular, what drove HCV to be a standard reimbursed test, and why is there a barrier for HIV being reimbursed in the same way, and what will it take to become standard? I was wondering, Dr. Schofield, is that something you might be able to speak to?
Well, first of all, HIV has been reimbursed. It's the new screen and then reflex and molecular with the new combinations in the last year or so that's caused confusion. A straight HIV diagnosis and screen and then confirmation have always been paid for those who have insurance. There is a much higher percentage of the general population getting tested for HCV that has insurance than the HIV population. Now, I'm not trying to slice and dice the demographics, but a lot of folks with jobs in their 40s and 50 years old had wilder or adventuresome youth, and through whatever habits or uses of things that contributed, HCV, 25 years ago, really, nobody knew what it was. You didn't have hepatitis A, you didn't have hepatitis B, you had the other kind of hepatitis, and nobody had a name for it. So HCV got a name, and people were told, I can remember, when I turned 40, they said, we're going to test you for HCV. I said, well, I've never had a risk population, but they still tested you anyway, because that was what the standard was under managed care agreements that had been worked through the different medical societies as the standard of care to try and capture and avoid long-term hepatic cancers and or transplants. And that's just the way it's turned out. HIV still can get reimbursed. It's the new combination of screen and viral load that's causing a little confusion. I mean, let me be very blunt. Insurance companies and their profitability is all around claims denial. And so if they've got anything that's different than what they paid for last year, they'll test you to see if you're paying attention. And if it's something they don't have to pay for, then you got to go fight for it. So that's kind of the differentiation as I see it, is that HCV came around a number of years ago with a full definition, and a lot of people who have good insurance got added onto their annual wellness check visit by their physician.
Okay, great, thank you. And we had a question about, in this era of rapid ART, is it perhaps advantageous to incorporate dual intended use claim assays, for instance, diagnosis and clinical management? I was wondering, Dr. Buss, what do you think about that?
I think, yeah. I mean, I am a fan of the dual intended use claim assays. However, I do think that laboratories need to kind of carefully consider how they're implemented, and perhaps importantly consider how they report things, and kind of communication with whether it's clinicians that are your customers, or the programs who are doing the communication with the patients themselves. Because I think if they're used correctly, there could be a real benefit, and maybe even cost savings, time savings, certainly. But you have to be careful in how you implement them, to ensure that the correct results are getting to the correct person, and that there's not going to be duplicative effort put forward at a later time.
Okay. Any thoughts on this one, Dr. Ledeboer?
No, I'm 100% in agreement with Dr. Buss. I think that there's absolutely utility to having dual use claims. And I think it's part of the challenge of also trying to get to reimbursement is making sure that we have FDA claims for both the diagnosis and the and viral load monitoring. But I do think Dr. Buss is 100% correct. How laboratories communicate that and understanding why it's ordered is going to be a critical component to reporting of those results and making sure that the interpretive comments that are included are applicable and are somewhat customized for the patient based on the order.
Okay, great. I had a question about sort of future testing. With novel single-step testing algorithms, will we be able to have point of care and home HIV viral load tests in the near future? And would that be possible from the regulatory perspective? What do you think, Dr. Ledeboer? We'll stay with you.
So can we get to a home single-step HIV qualitative test? Yes, I think we can definitely move that direction. And I think that's something that the FDA has shown willingness that they would consider. In terms of viral loads and home viral load testing, that's going to be a much more complicated both interpretation and discussion with FDA on that one, because there are so many different factors that contribute to this. And there's concern around, what is a patient going to do based upon that information? Because ultimately, if we get a viral load, that's an important conversation that you have together with your healthcare provider to develop some shared decision making around what is our monitoring strategy going to be and what is our treatment strategy going to be. So I think an at-home monitoring claim might be much more difficult to get to. Certainly a CLIA waived or potential at-home blood spot based test I see moving forward into the future. But again, as several of us have pointed out throughout the webinar today, the first step in really getting to that is going to be we have to see changes in the guidance that would ultimately accept a single step molecular test for diagnosis. And that's going to take changes in the guidelines as well as changes in how the U.S. Preventative Services Task Force ultimately sees HIV screening and the role of nucleic acid testing in HIV screening.
Okay, great. Thank you. Dr. Buss, what do you think about this one?
Yeah, I mean, I agree with what was said. And I think what I would predict might come first is home collection associated with some of the laboratory tests that we already have available. I did mention alternative specimen types, dried blood spots or microtainers, things like that, where patients can collect a sample at home and then send it to the lab. Now, we're not there yet, right? We have some regulatory requirements that need to be met. I think companies need to take home collection kits to the FDA because my understanding is that laboratories are not able to validate home collected specimens just like an LDT. That's a separate issue. So it's really on the products that are available and what gets FDA cleared.
Okay, great. Thanks. And I think we have time for one more. I know there's been some, discussion at FDA about plans to begin regulating LDTs, and I know, that has potential impacts. I'm curious, Dr. Ren, does that have any impact on your thinking around your lab's HIV, HCV testing practices, or as you look to the future?
Yeah, I think there's definitely some impact because it's if it's an FDA approved test, it will be much easier for laboratory to go through the verification, so it will be one of the driven points for the laboratory to adapt to this, to bring in this test into the laboratory. And the especially also the LDT, the throughput is not as great as the FDA-approved tests, laboratory, if have stronger research background, relatively will be easier to develop their own assay to go through the validation process. So in terms of FDA, yeah, if it's FDA approved, basically follow the protocol will be relatively easier to go through this process. That's the driven part.
Okay. Great. Well, thank you very much. I think that's all we have time for today. We'd like to thank our panelists and our sponsor, Hologic. If we didn't have time to get to your question, we will try to follow up with our experts. And as a reminder, please look out for the survey after you log out to provide your feedback. If you missed any part of this webinar or would like to listen to it again, an archived version will be emailed to all attendees. Thank you for joining us for this 360DX webinar.